Richard Dale, hi. And welcome to our Council of Governors meeting in public, which will run from 6 p.m. to about 7:15. Very warm welcome to our governors, our Council of Governors, board members, senior executives, and to members of the public who are observing us today at our Council of Governors meeting. The shape of the agenda, we're going to focus on three big topics. An update on development at the system level, ICS, hence our two colleagues, Francis and Richard, joining us for that. We're also going to focus on our operational performance as we lead up to winter. That is clearly a matter of top priority for us as a trust. As there was huge interest from governors expressed at our last council, we're going to have an update on our digital transformation, but in particular on our electronic patient record system and the huge launch that we had recently in the last couple of weeks, something to celebrate. But I'm sure governors have lots of questions. If you don't mind, I'm just going to whisk through the opening admin very quickly. We're pledged to do it in a minute. And then we'll get on with the agenda. So apologies for absence. I have apologies from Vishal, Victor, Anna, and Peter. We're quorate in terms of any decisions we need to make today. Declarations of interest. Are there anything? Is there any interest that anybody needs to declare, particularly pertaining to today's agenda topics, please? Okay, minutes of the meeting held 13th of July. Everybody happy with the minutes? If not, please do raise your hand. Yeah, we're good, so we may sign off the minutes. Action log. Apologies, just need to orientate myself in the deck. I don't propose to go through all of that. Most of the items are ongoing or closed or not quite due yet, or are on the agenda today. So it all looks pretty okay to me. Is there anything around actions or any matters arising from the last set of minutes, for instance, that you feel we haven't captured? Okay, that's been swift, fantastic. So that's our opening administration out of the way. Now, I'm very conscious, Caroline, that you need to go in 10 minutes. So may I propose, colleagues, if you don't mind, a slight reordering of the agenda a little bit. So can we go to Caroline's Chief Executive report, but if you could keep that brief, Caroline, because I think what you're about to say, we're going to cover a lot during the agenda. And Sneha, I know you have an issue around corporate governance that you'd like to raise, and I think we should do it whilst Caroline's still in the room. Can we tackle those two very quickly, and then we'll bring our guests in for the ICS update. So Caroline.
Okay, thanks, Mark. I will be very brief, actually, because actually most of what Debbie and Alan and John are going to talk to you about are what I would have reported. So do you remember I've got 4 delivery priorities, and I wanted to talk to you particularly about digital EPR. We're going to talk to you about how that implementation has gone, and I won't be here when John and Alan talk about it, but I just want you to know that they've done a fantastic job, and a lot of people have worked really, really hard to make the go live work. And actually, we should be really proud of it. It's a fantastic platform from which we can now practice really brilliant 21st century medicine. People will find this implementation bit, you know, it's change, and change comes with hard yards and hard conversations, and some things haven't gone, you know, quite as well as we wanted to, and you'll hear lots of that. But actually, overall, we should be really, really pleased with what the team have done. So, you know, to John and Alan and Debbie, actually, because Barnet have had an upgrade in all this as well, and that was hard. So I won't be here, but I want you to try and celebrate some of that stuff if you can. So digital, we've done that. Much more to do to become a truly 21st century hospital group, but that is what we've been doing over the last couple of weeks since we last met. Secondly, I want to talk to you about the system, and again, Debbie will talk a bit more about this. It is very, very busy wherever you look, whether whether you look in primary care, in social care, in community services, mental health services, or our own hospital services, it's really, really super busy out there, and we're feeling the heat. So our emergency departments are regularly seeing sometimes 20% more patients than they normally would at this time of the year, and our staff are really feeling that heat. So we're working really hard with primary care in particular and social care to try and find some different models of care to actually get those patients treated more quickly. So you may hear more of that later on. And then I can't not mention waiting lists. Debbie, I know you're going to talk about this in more detail, actually, but we have made some really good progress in trying to get those patients who've been waiting a terribly long time treated, and some of our patients are still waiting a long time, but the team is working super hard. And despite putting a new EPR in, despite having a pandemic where we've got at least 2 wards on each site out full of COVID patients, under your leadership, Debbie, we've managed to do some really good work. So thank you for that. And then the final thing, of course, I can't not mention our staff. We have a wellbeing programme which is now starting to think about the physical health of our staff as well as their mental health. You've heard us talk a lot about mental wellbeing of our staff, and all that work continues. And we'll continue to do more and more. And at some point, it would be good for us to showcase a bit of that for the governors, Mark. So I'm going to stop there because of time, and my colleagues will take more questions later on.
I think if it's about operational performance, whether that's ED or waiting lists or cancer performance, if it's about digital transformation, including EPR, if it's about the wider system, our upcoming topics will address them. So I would perhaps ask governors to reserve their questions for those other speakers there. But if there are any other questions for our Chief Executive, please do raise your hand. Nope, I think that was good. You got away lightly this time, Caroline Clark. But whilst we've still got you here for a few minutes, Sneha, may I ask you to lead us on a sort of verbal item around corporate governance and how we sort of run ourselves, really, and what you would like to raise whilst we've got Caroline here.
So Caroline has ideated a session probably to discuss it separately. So I'll pick this up with her in my one-to-one, if that's okay. I think, Caroline, if you suggest that, I think we'll work that ways. So I think we can do that together. So probably I'd recommend and I can brief the council after I've caught up with Caroline on it. So I'll take it from there. Thanks, Caroline. Really appreciate it.
Great, thank you. Yeah, if we're all happy with that, that seems very sensible to me. Thank you very much. In which case, Francis and Richard, sorry to have kept you waiting. But really pleased that you've joined us as guests for an update on the health and social care bill, is how we've called it. But I don't think we're after a legal readout. Everybody's got Mike Cook's, the chair's sort of recent note, so everybody's read that. But it was really for you to share your perspectives on ICS developments and how we should engage, and we'll have a bit of Q&A. But I wonder, Francis and Richard, if you might want to start by introducing yourselves.
Thank you. Well, I'm Frances O'Callaghan. I'm the Accountable Officer for the CCG.
And I'm Richard Dale. I'm an Executive Director of Transition, and I'm working with partners to help us through this next period of time as we develop the ICS.
So, Mark, if it's helpful, I thought I would sort of touch on 3 broad topics: the development of the ICS, the role of the Provider Alliance, and then I think some points about your relationship that is flourishing, I know, with the North Mid, particularly because I think that takes us into the discussion on place and the importance of place. So very briefly, and Richard has some slides and he will follow on from me. The ICS, as you know, is subject to legislation. It's going through the House of Lords at the moment, but we are still anticipating that the formal statutory body, which is the Integrated Care Board, will be established on the 1st of April 2022. The ICS will be finding its way with its trust board colleagues, its local authority partners, the voluntary sector, primary care, etc. So it's definitely a period of change and integration, but I think it's a period that we're looking forward to in terms of everything we're trying to achieve. You will know that within the bill there is an expectation in terms of a new statutory requirement for NHS trusts to collaborate And obviously we welcome this. It builds on the work that we've done throughout the pandemic and the work that you as the Royal Free are doing as part of your group work and with the North Middlesex. So we believe that the foundations are in place for the ICS to develop. Within the changing landscape, we will see the continued development of the Provider Alliance. You probably know that within NCL, the Provider Alliance is quite unique in terms of it being an all-in Provider Alliance. It's not just acute, it's mental health, community, acute and primary care. And whilst we are sort of recognising that that brings its own set of challenges, we believe it's the right thing to be as inclusive as we can at this stage. And the way that the ICS will relate to the Provider Alliance is something that we're spending a lot of time working through in terms of the role of the Strategic Commissioner and the responsibility around population health, and then the delivery. I do want to be really clear about the importance of place, and I'm sure Richard will touch on this, but when we see, and Caroline has just mentioned this, the pressures that particularly Barnet and the North Mid are under, they're not alone in that, but we recognise there's particular pressure there. I feel very strongly that the collaboration around place, rather than the ICS trying to fix these things or a single institution trying to fix these things, will really come to the fore as we work together in terms of the partnership needed to ensure people are looked after safely in the right place with the right professionals. So I'm going to let Richard speak briefly. As I say, he's got some slides, and then really happy to take any questions.
Thank you, Francis. So I'll promise not to take too long with slides because it always kills the conversation, but there's just a few things I think are worth sort of providing so that we can kind of stimulate a bit of debate, if that's all right, Mark. So I'll just quickly run through them quickly. So firstly, I suppose we make no apologies when we talk about the integrated care system, just to start with the resident population, because that is who we're here to work for and improve the lives of. And in North Central London, there is a very particular context about how we have a large amount of diverse populations with some really high rates of deprivation and some areas of low deprivation. And actually in each borough, there's a very different makeup of local communities. And we've seen through the pandemic how working alongside voluntary sector and our communities can mean we reach parts of the community that previously we weren't very good at always working with. The other part, just I suppose to throw in, is, you know, in North Central London, we have got some fantastic institutions, all who have unique assets. And I guess one of our jobs as we move towards an integrated system is to get the best of this and to see how it can work together to improve the outcomes for our populations. And that's a very different way of working. If we go back to a few years ago, where there was much more competition across organisations. So, you know, we've got riches in North Central London, and our job is to try and get the best out of that for the local population. I suppose one of the things people always ask us as well is what are we aiming to do with an integrated care system? And really there's 4 key aims. One is around tackling inequalities. So how do we find out where there are inequalities in terms of outcomes, and how can we work as a system to tackle it? There's a wider thing we're being asked to do about improving population health. So this is looking at the things that are wider than simply healthcare provision to support people to live healthier lives, and working with partners to do that. There's also a challenge around productivity. So if we were going to think as a single system about how we invested money that came in, we'd probably do it more efficiently than we have been doing. And that's another challenge for us collectively to think through. And then there's the further bit about the NHS is a big employer across our part of London. And what are our responsibilities as large employers about the broader health and economic development of the communities that our staff come from as well. Just to highlight that actually the pandemic has seen us work like an ICS in many ways, and your staff across your organisations have been part of this. I can see some of the colleagues I've been working with very closely on things like vaccine and other areas. But just to pull out a few examples, so our critical care teams now talk daily across the sector about the levels of capacity and how they can support across organisations, either transferring patients or staff, and very much operate as a system and as a network. We're seeing much greater collaboration, as Caroline described, around primary care and how we respond to pressures across the system. And, you know, we've also seen some quite innovative approaches around how we manage discharge with joint teams with the council and a shared bed base to make sure that people are able to leave hospitals safely and as quickly as possible. The last bit I'll just bring up is, you know, if we're asked to what is a ICS, there's kind of 3 key levels that we talk about. The first one is around a neighbourhood team. So this is very much building on primary care, coming together to manage their frailest patients proactively and in ways using a broader team than just healthcare, so social care and local authorities. Place-based partnerships are then at a borough level, where we can start to tailor services around the local community's needs. And then finally, across all the 5 boroughs, this is a kind of ICS construct, which really, as Francis alluded to, is about strategic commissioning, so long-term planning about how we fund different services, and then also putting in place key enabling actions like a single capital plan across our sector, and joining up a health and social care record so that patients don't have to repeat their story every time they come to a health or care professional that's all joined up in the background. So those are kind of the key things we wanted to highlight today, I guess, Mark. Really keen whenever we come and talk, because it's such a broad topic, to answer any questions on detail, but also get ongoing feedback about how we talk to residents and our stakeholders meaningfully about this, because it's quite a large topic. So really grateful for both questions and feedback.
Thank you. And they can be very technical speak, aren't they, for those of us who work in the NHS, and I count myself in these days, having gone native. Great, thank you so much, Francis and Richard. Colleagues, any questions? If I may, sorry, I'm behind it. Anthony, please.
Hi, I'm very interested in across the integrated care scheme and end of life provision. And I understand that is it Coordinate My Care is going to be abolished at the end of March, and you're bringing in a whole new system in the beginning of April to make sure that old people, their needs are known by everybody across the system. Could you say a bit more about that?
I'll start. I may not have the detail that you need, but I'd be very happy to speak again or to send some information through. So yes, you're right. The Coordinate My Care programme has been given to a new provider. And Charlotte Benjamin's on the call, and she may be able to give a bit more detail than I can. I mean, essentially what we're trying to do, as you say, is we're trying to join up the patient record in terms of people understanding exactly where patients are up to, so that they are not subject, particularly at the end of life, to being taken to hospital, etc. All of the things they've agreed with their palliative care team. Charlotte, it might be helpful if you came in on this.
Thanks, Francis. I mean, just to say, this was a pan London procurement, so it wasn't we weren't specifically involved. It was done with West London was leading on the procurement, and I think CMC is fantastic as a launch pad to start having integrated records for end of life care. Digitally, there's a lot of problems with it, and it doesn't it doesn't take information from different systems, and you have to upload things separately, which is a huge disincentive for people working in the system to actually record on a separate system anything to go in. So it's a challenge to get people to record it first and then to update it. So what they're looking at, what has been procured is something that's more digitally advanced, more digitally able. But CMC has been an excellent introduction. I think people find, there will be the transition, people will find they have to get used to it, but hopefully working with something that's much more digitally enabled will have huge benefits, and it will be easier to input information, which in time will benefit patients hugely.
Thank you for that. Chris Ham.
Yeah, Thanks, Mark. Hi, Francis. I wanted just to ask for a bit more detail around the Integrated Care Board that will be responsible for the leadership and the governance. How far have you got in determining the membership of that? And I guess for those of us on this call, how will the voice of Royal Free London Hospitals be heard on that board?
Yep, good question. So as you know, there are two areas in the legislation that make particular reference to the governance of the board relationships within the new ICS. So one, as you say, is the Integrated Care Board, and the second one is the Integrated Care Partnership Board. And Mike Cook has also introduced a third arrangement, which is the Community Partnership Forum, to get as much breadth as we can in terms of those groups. The Integrated Care Board is operating in very shadow form at the moment, with the chairs of the provider trusts, as well as the local authority representative, as well as some of the senior executive staff, and that's been running for a little while. It's recently changed, but at the moment that's sort of in place for us to work on. We've also had an Integrated Care Partnership Board, which is a broader group of people in terms of the local authority leaders and other senior executive colleagues, with the Community Partnership Council being much more inclusive of the voluntary sector particularly. So as you will also know, Chris, within the legislation there is an expectation that, as well as a chair, a CEO, a finance director, a chief nurse and a chief medical officer, we're asked to appoint 2 further independent non-executives, and we're also asked to ensure that we have provider representation, local authority representation and primary care representation. And that's sort of as a minimum. I am certain that Mike Cook will want to build on the partnership board arrangements that he has put in place, recognising that you can't have everybody around the table, but certainly in this instance the Royal Free does have a very specific voice through Mark at that meeting. We've also obviously running and will continue to run what we've called the sort of the gold executive group that all of the CEOs from the system are on at the moment. Again, we'll be working it through and changing it, but I am certainly of the view that we cannot effectively run the ICB without very strong provider, and I'm not using the word representation because I don't believe in representation as such. I believe in accountability, partnership, and sort of shouldering that load in terms of what we're trying to do as a system. And then finally, I would just reflect on the relationship between the ICB, the Integrated Care Board, and the Provider Alliance, because clearly there will need to be a synergy there in terms of what we're trying to deliver consistently across NCL, but again ensuring that the providers have a very significant and strong voice in terms of the development of the ICS. So some is statutory, as you know, and some will be subject to much more sort of local arrangement. I would just emphasise the place bit again, and I know I'm preaching to the converted, but the importance of place and that place leadership is going to be absolutely critical in whether or not the Integrated Care Board can be successful.
Thank you, Francis. And you know from your prior work in East London that where the concept of place is stronger actually than in North London, a lot more history. You know, if you look at Tower Hamlets, yes, Newham, and the sort of integrated work, and in fact the birthplace of primary care networks was Tower Hamlets. So, and I think in North London we tend, Chris, to be a bit more top-down traditionally, probably in an effort to control the many voices that we have across an incredibly complicated landscape of healthcare providers. So, and I'm really pleased to hear, Francis, that kind of going into next year, we need to correct that in many ways and put the emphasis back on local place and what we need to do locally. Any other questions or thoughts, colleagues? I've got one, perhaps on behalf of the governors, Francis and Richard. I was on in a a discussion session with the governors just before this council, and they were very interested to know what we should be doing at system level to help with winter pressures. So this is a very immediate thing, and is there more we could be doing as a North London system?
Well, I'll start. There'll be others in the room that are more expert than me. Sorry for the echo. I know Debbie's on the call, and she's the lead for the urgent and emergency care pathway. So obviously winter pressures come in a number of forms. We know that whilst the COVID inpatient numbers are quite stable at the moment, the actual number of COVID infections is going up again. So that will be one component. We know that primary care is under a huge amount of pressure, and that there's been a particular investment announced in terms of winter for primary care, which we're working through at the moment. We know that LAS is under pressure, and all of this combines for you in the trusts to see large numbers in A&E. I think we know that there are a significant number of people in A&E who perhaps could be better cared for elsewhere, but there are reasons why they're going into A&E. So I think the support that we're putting into primary care, into 111, and actually into the work we're doing with the voluntary sector, particularly in terms of them being able to reach out into communities and explain what's available, what the best thing to do in a particular situation is, so that A&E is kept safe for the people that really, really need it. I think that we have a good system in NCL built on the back of the pandemic. We've got a good escalation programme around particularly critical care beds, but also around ambulance conveying and the cascade when the pressure in the north, which is where we feel it the most, is really felt. We are concerned about the length of time it's taking to hand over patients in A&E. So the ambulance arrives at A&E, but it can take up to an hour sometimes, or even longer, to get the patient out of the ambulance and into a safe place in A&E. So the work that Debbie and others are doing around ensuring that that ambulance handover is safe, but is as swift as possible to allow the ambulances to get back on the road, is a big part of what the trusts are contributing to this. So and that's really why I make the point about place, because actually it will be a Barnet conversation, an Enfield conversation about how do we bring the right GP support in, which voluntary sector organisations are we working with in terms of communication. So a huge amount going on, and NHS England have received our winter plan, and we are in lots of conversations about that, but others may want to comment.
If I may, we straight after this, we have an operational. I was talking to mute, wasn't I? Francis, thank you very much for that. And I was going to say that straight after this, Debbie and her team are going to talk about, and John are going to talk about the pressures we're currently experiencing and what we're doing more widely. So I think we can pick that up then. But I just want the governors to be alive to the fact that we are working as a system. But also to manage expectations that, you know, we are already in October and we are in pretty extraordinary times. We can't have planned for a lot of this, particularly the impact of COVID. So there will be things we need to do short term, both as a trust and in partnership with others. But actually, what will be important is what we do next year to avoid another tough winter. And that's, I think, when the ICS and the trusts can demonstrate a new partnership. Richard, did you want to come in?
Yeah, it was just to add a really practical example, Mark, of system working that I think it wouldn't have happened 2 years ago. So we've done a situation report across primary care, and we know as smaller organisations, they're very hard hit when people go off sick. And actually one of the big groups that are having to take time off are reception and administration staff. So what we're doing is we're working with the current acute staff banks who normally wouldn't provide staff to primary care to train up staff in primary care systems and processes who can then go in and support primary care. So, you know, that's something we just wouldn't have done 18 months, 2 years ago. And it's, you know, it's quite a nice example of the ICS providing a bit of a framework and linking up across workforce to enable that support. And I think, you know, that's an example. We need to do more of that. I think we don't get it right first time because it's difficult to do it the first time, but we're learning as we go. And I think we're really keen to see how we can build on things like that as we go forward.
Great, thank you. Thank you. Well, Francis and Richard, I'm conscious it's 6:30, and you've doubtless had a long day, and we're going to let you go at this point. But just to say, really pleased you've joined us. I really wanted our governors to meet you.
Thank you.
And hopefully in a future update, we can meet in person. I think it's really important as a foundation trust that our governors are as involved in the development of regional systems, because we all care about outcomes in the same way as board members are. So thank you very much.
Thank you. Good to see you. Thank you very much. Thank you.
Okay, I hope colleagues found that useful, and we'll keep coming back to this topic. I am very keen that we stay very close to regional developments. That's a good segue, I think, Debbie, to an operational update, particularly around waiting lists and the pressures we're experiencing across the trust. So Debbie, over to you, please.
Thank you, Mark. I'd like to start with, there's a lot of echo. I'll carry on. With waiting lists, if that's possible. I did supply some slides, but they didn't make it into the pack. So I just wonder if, Russell, you could share them. Thank you. So as Caroline said, one of our 4 priorities is making sure that we treat people on time. I think the council are very aware that our waiting lists are challenged. Before COVID, we had about 76,000 people on a waiting list. We've now got 97,000 people, so it's a lot of people who are waiting for care, and far too many of them waiting for a year, or cases over 2 years. So that's why I want to start with the patients who are waiting over 2 years. So could you have the next slide, please, Russell? Thank you. So we set ourselves a trajectory in partnership with NHS England and the ICS.
Debbie, your voice is dropping occasionally.
I'm getting a lot of feedback as well.
Could I ask everybody please to go on mute, or whoever's administrative rights, just mute everybody bar Debbie. Thank you.
Thank you. Well, that's better. So yes, we had a trajectory that by the end of September we would have 400 to 104 week waiting. We did come under that trajectory. By the end of September, we had 335 patients, which is still 335 too many, but we've made significant progress. We didn't make quite in areas that we thought we would. So some services did better than they predicted, and some didn't do as well. But we've now got a trajectory for to the end of March, where we think we have 104 week waiters there. I think it's fair to say that when we started reporting, we had the highest number of 100 waits in the country. We've now got the 6th highest, so that's what we want to be, but our position is improving. We do seem to be reducing our numbers well. Can I have the next slide, please? So this is a trajectory for to the end of September. I think the other area that we're really focusing on is obviously our 52-week waits. Our last reported position was 8,455 patients who've been waiting over 52 weeks for treatment. And that's down from about 15,000 in March. So again, we've made significant inroads into that number, but we still have a significant amount of work to do. Each service is having a individual trajectory set for its 52-week waits. It's not going to be quick to clear, but everybody's focused tremendously hard on this. We really want to make sure we get our patients treated as soon as we can. Should I leave it there, Mark, about the waits, just see if there's any questions?
Yeah. Firstly, Debbie, I think it might be your microphone or something. There is a very distinctive issue which is not echoey really from everyone else. Don't know if you got a chance. Quite hard to follow actually. But I think one thing it may be worth explaining to our colleagues on the call, because when it was explained to me, Debbie, there was a sort of eureka moment, which is why we've got so many plastic surgery waits that are over 104 weeks, which is 2 years. So I think it's why in two perspectives. So why have we got so much plastic surgery? Because of the types of services we offer in London, and secondly, why they are particularly hard to clear. So perhaps we could start there.
Okay, I can't seem to fix whatever my problem is, Mark. I just wonder whether I should go off and come back on again.
Yeah, and I can answer that question myself anyway, because you've educated me.
John's very well versed in the plastic.
Yeah. Okay. Perhaps if you could do that, Debbie. John, may I ask you to jump in there?
Yes. So I hope I can do justice to Debbie's previous explanation. So we do provide one of the biggest plastic surgery networks in the country, is the first thing to say. It's not simply for the people of North Central London, but Hertfordshire and beyond. And also that service provides trauma services for people with hand injuries and other emergency services. And about 3/4 or more of the service is actually dealing with cancer surgery, which is prioritized and which usually comes up very urgently. So a lot of plastic surgery capacity is devoted to emergency or very urgent cancer surgery. Therefore, we continually have to do that. And the 104-week waits are for less urgent, sometimes cosmetic, but sometimes really important to the for the patient. In fact, almost always. But invariably, the patient also wants to choose who their surgeon is because they've got a relationship with them. So how we've started to do that is to really focus on the long waits. And I think you can see we've made really great progress on that. Patients still are making choices to delay the surgery because some of it is not emergency or urgent, and they're making choices based on the risk that they perceive about COVID in the hospitals. And meanwhile, we are continuing to drive more and more patients from our very urgent cancer pathways into that. So as quickly as we remove them, patients are coming onto our lists. But there's been a real progress on the longer waits, and we continue to really focus on that. So I hope that's the explanation that you had, Mark. But that's our explanation. And our plastic surgery team are amazing. And of course, most of the patients who are waiting to be treated only want to be treated by the surgeon that they have a relationship with.
Thank you, John. And also, as I understand it, for instance, if the work is breast reconstruction after cancer treatment, for instance, just scheduling theatre require an anaesthetist, a plastic surgeon, a breast specialist. So I think it's just, because we run one of the largest plastic surgery networks in the country, we disproportionately have to bear the responsibility for some of these very long waits. That's not to absolve ourselves as need to clear it, but I hope it goes some way to explaining why we're in this situation in the first place, along with similar other colleagues across the country. But I think to Debbie's point, it's good that we are starting to make progress in reducing that extraordinarily long wait, which is not a good experience for anyone. Debbie, have we got you back?
Yes. No, I'm still doing it, aren't I?
No. You're good.
Okay. So I think to Francis's point, Mark, as well, about looking at this as across the system. So we're really doing work with our partners across the system on how we might do some smoothing of referrals. So looking at if we've got particular specialties that might be challenged in one sort of subspecialty, if you like, is there another trust that can take some of those referrals for us? Because to John's point, we know that once a patient has a relationship with our consultant, they they don't want to move, they want to stay with that consultant. But if we can start them off at the beginning, a relationship with another hospital, and that means that they would probably stay with that hospital. So for example, we've done that with some particular hand surgery that's being done at the Whittington currently. We'll review that every 6 months, and when the waiting lists become more equalised across the system, we'll start to open them up again. But I think, you know, there probably is more we can do across the system, but people are working well together.
Thank you, Debbie. Before we go to A&E and operational update, where else would you like to take us?
I think happy to go to ED.
Please, yeah, and then we're open to Q&A. Thank you.
Yeah. Okay. So I think as Francis described at the beginning, and Caroline, our EDs and the UTC at Chase Farm are all under significant pressure, seeing much higher volumes of patients than we have been previously. And as Francis said, there's lots of reasons for that, which probably we don't need to rehearse here. But I think it's you know, I think we all feel very proud of our teams who are consistently trying to think of a different way to deliver services to make sure that patients don't have to wait any longer in our ED departments than we need to. And you know, they are concerned about the volume of patients we have in the departments at any one time, because they worry that, you know, they might miss the one patient who really needs to be seen quickly. I think we have had some staffing challenges. So we've had some vacancies. Staff are, you know, they are tired post-COVID, and they've been a bit less reluctant to do extra work than perhaps they have been in the past. We have now got new recruits coming in, particularly in nursing. So at Barnet, we've got nearly about 40 new nurses about to join us in ED, and that we heard today is encouraging the staff, because they feel that something's happening and they're starting to see new faces. We sort of, clearly it's a whole hospital, whole system approach. It's not just the ED staff's problem, it's all of our problem. And so all the hospitals are working together to try and make sure that we get patients flowing through the department, flowing through into the wards, and flowing through out back home. I think, you know, there's significant concern about the winter, considering what everyone's been experiencing through the summer and into the autumn. You know, I think we are really focusing on our staff's well-being and their ability to continue to cope with the pressure that they're dealing with. We're obviously keeping a really, you know, absolute focused eye on the safety of the departments. We haven't had any serious incidents reported through the departments. We're looking to see other places patients may get treated, and we're trying to sort of think about ways that we can, once a patient's registered within the ED, even if they don't, maybe their condition doesn't require that they be there, they're very reluctant to move somewhere else. Understandably, they'd rather wait. So we're trying to think about what we can do differently right at the front when people first arrive. You know, we clearly don't want just to say go somewhere else, because that's not fair. So we want to work with partners to make sure that we've got accessibility for other places that people can go for treatment, or looking at how we do things differently within our department. So running hot clinics that people can refer directly to, using the UTC differently, looking to see how we might use some of the GPs we already have at the front door differently. So I think there's lots of innovative thinking going on, and I just think we have to support our staff in delivering what they think will make the difference.
Thank you, Debbie. Really appreciate it. Colleagues, I know governors, this is number one for you when we chatted before the council. So please, if you've got any questions or comments, please do come in. Sneha?
So Debbie, one of the things that you were during COVID time, is there any feedback from my voice as well? Should I drop back and join?
We can hear you clearly, Sneha, and Emma tells me by message that we've had Teams issues all day. So much as I accuse Debbie's equipment, microphone equipment might not have been that. So just keep persevering, Sneha. We can hear you clearly.
Great, thanks. I think, Debbie, my question was initially during pandemic, we were telling patients not to come to ED. Now we are overflowing with patients. And I think one of the key things is around patient safety during the infectious diseases and winter coming soon. So it'll be a combination. How we are making sure that both the patient and staff will be how are we going to manage that, because there'll be a lot of stress on patient and staff, considering we've not experienced a combination of the COVID as well as flu season combined. So it'll be just good to know how we are going to manage that.
I think it's a really good question, Sneha, and clearly it's something that people are thinking about a lot. So obviously, if you go to any of our EDs or our UTCs, they look very different now than they did pre-pandemic. So you know, the footprint of the Royal Freeze increased huge. You know, it's increased to have sort of green and blue areas. At Barnet, we've put in lots of extra side rooms in the ED that we didn't have before. It's one of the reasons why we're struggling a bit, and you might hear people talk about not being able to get inside the ED, and that's because we still have to follow distancing within the department, so that causes us some constraints. So even though we've sort of put extra space in, it's still a concern. So I think you're absolutely right. We've got the pathways. It's managing the volume of patients within those pathways, and you know, that is one of the reasons why sometimes we struggle to get people off of ambulances. It's just we haven't got a physical space to put them. So it's a good question, and one that everyone is you know, like I say, thought out pathways, but just managing the numbers within those.
Thank you. Bimbi, hi.
Hi. Yes, I've got a question for our exec colleagues, and it's just really from the Board of Governors. I mean, obviously, there's been a lot of flux in the exec team with lots of new faces and new members, as well as you know, our new chair. But also there's a lot of uncertainty around lots of other areas with the COVID recovery and the expectations, the EPR sort of cut over and how that's progressing. I suppose the question I really want to ask is, how can we as a group of governors best support you in delivering what you need to do? So it's really sort of asking you how you can sort of maximize the benefit of our input to supporting you.
That's a great question, Bimbi, and I might go to more than just Debbie. So just ready exec colleagues with their wish lists, but not wanting to turn this into a huge discussion. But I think it's a good question about how the Council of Governors can help. And any thoughts, colleagues, exec colleagues? Emma?
Hi, Mark. So hopefully I've not fallen foul of the same echo. So I think there's probably a couple of things really. So I think one, you know, you've sacrificed your time to be our governors, and we are eternally grateful for that really, because you are our greatest champions and supporters, both of us as individuals and of all of our staff on behalf of our patients. And I think, you know, it's actually a privilege for us to get to hear your feedback. So I think partly about being really engaged in these meetings and our trust board meetings and all of the information that we share with you, and actually using that to engage with the membership, which is the people who put you in your positions apart from those appointed governors. So actually, I think that's really important, you being that voice and reaching out to the community and the membership that you serve, because you're a really important way of doing that. And I think, Bimbi, I know you're a staff governor, and for our staff governors, I think it's really important as well to kind of feel that the council are supporting us, and for our staff governors to share that as well. So we work really hard, as you know, to try and share what's going on in the organisation and be really open and accountable. But actually, you can give a very unbiased view in a way that we can't externally, and also by the information that you're privy to and the board subcommittees that you sit on, you're able to have a real insight into some of those daily challenges. And it is going to be really challenging in the NHS, especially for the next 3 to 5 years. There's not going to be a magic wand. And I think you all appreciate that. And Debbie's presentation definitely shows that. We're working really hard our staff have done brilliantly to cut down the numbers on the long waiters and the waiting list as a whole. If you think about us actually in terms of partly being a victim of our own clinical success. So actually we really need that. If that was the one thing you could do, I think that would be brilliant if you could carry on doing that.
Great, thank you, Emma. Any other thoughts, colleagues? Ravi, Debbie, any thoughts? John, and then Ravi.
I think for me, one of the things that governors can really help with is some of the complexity and interconnectedness of what we're talking about. So if I use the example of demand smoothing that Debbie referred to earlier, I've had lots of concerns that the Royal Free is no longer providing cataract surgery. Well, in fact, what we're doing is a real triumph of collaboration across North Central London to allow us to treat the maximum number of patients in the most effective way for them by working together. If I think about the ED department and the pressures on primary care, we really are going to have to work in a different way. And, you know, there's a narrative sometimes that this is, if only people were seen somewhere else, they wouldn't come to ED. But actually, we can really help. The hospital's got a responsibility, and this is to help primary care in that, you know, primary care shouldn't be dealing with questions about our processes and patients on our waiting list. And we that message of collaboration to solve really big problems that come from all sorts of angles is I think that's where governors could really help. And I include EPR in that. In many ways, EPR. Why would you do it right now when people have had so much put on their plate? But actually, it's the only solution to us trying to connect up what we do across the Royal Free Hospitals to allow us to connect to our primary care colleagues, to allow us to get the information that we can manage these really large and intractable problems. So I think if governors can help with understanding and explaining that complexity to colleagues, it would be massively beneficial to us.
And absolutely, John, lots of nods there. And let's hold that thought on the EPR because that's coming up next on the agenda. Ravi, final thoughts on Bimbi's question, and then I'll move us on from the operational update.
Yeah, I'm in agreement with Emma and Jonathan, just to build on their comments when I was starting EPR is about that two-way communication. So I know with having been involved with the EPR implementation, actually we've had some really useful comments and questions from governors, which do help us with implementing the EPR. But I know Alan will get into this, but it was one thing implementing EPR. We now need to actually improve adoption and actually ultimately optimise and improve how we use that EPR. And I think governors' role in that two-way communication around that be really helpful. Second point really was also just to know the governor's role in obviously in board subcommittees, which Emma referenced. And I know that, for example, I know Linda is now a member of the Group Access Committee. We had the first meeting in August. We've got the second meeting tomorrow. I know Linda's going to give an update later on in the meeting. But from speaking to Linda before tomorrow's meeting, governors can ask a different set of questions really, and can really help us with that conversation as a board committee to make sure that we are really covering things properly, but also kind of discussing and communicating things in the right way.
Thank you very much. Thank you, Ravi. Debbie, Emma Cox has asked a question in the chat window. Perhaps you could reply to that in the chat, as I think we can be probably pretty direct about that one in terms of what our views and position. It's a good question from Emma. Thank you so much. Can I just say, as chair of the council, that we want to reflect, I think, for the record in the public meeting, that we recognise these are extraordinary times in terms of the demand on our hospital services, and that it's a very, very tough and challenging entry into the winter period, and that the council of governors would thank all staff for their ongoing commitment, hard work and sacrifices. And I think we ought formally to acknowledge that. Thank you. And thank you, Debbie, for leading that update. Which moves us on then to our digital update with a particular focus on the electronic patient record system. I don't know, Alan, are you leading us off on this?
Yeah, I'll just give a quick 3-minute conversation and invite questions, because I think a lot of members of the governors know a great deal about this. Just to give you an idea of timeline, the business case to extend EPR was in July 2020. The EPR itself is to expand the platform that already exists at Barnet and Chase Farm and extend that to the Royal Free Hospital. At the same time, we also upgraded the administration of the PAS system, introducing the ED FirstNet module upgrade, and there was a couple of new areas of facility, ICU module being the main one. Just to let you know that this is a joint project with West Herts Trust, Watford to you and me, and that means that by the end of this year, 1.6 million people will have this as their main secondary care EPR. Just to let you know that we took our established computer systems down on the weekend of the 30th of September and it went live 3 days later. It was used in earnest at the Royal Free on the Monday afterwards, and it goes live in Watford in a month's time. Technically, we're in the period called, just finished a period called early life support, which those who have done computer rollouts before will know there's an intense amount of technical and executive help all on site, backed up with some educational help in the form of floor walkers and super users. We did in that period reduce some elective work. Some areas that could reduce that we did down to 50% so that we could help the clinicians and the workers get used to the system. Just to let you know that the immediate benefits that we've got, they're live pretty much out of the box. So we've got early adoption in all areas. We have not had any areas that have fallen over because of this. There's a great deal of planning that went ahead of that, and we're very pleased with the initial implementation. We get the drug safety straight away. Already we're looking at the metrics of the allergies that get brought up and the drug interactions that have been highlighted, and they come in a report that I get daily. It's very satisfying to see that. The digitized CPGs, which you know is a central tenet of how we're going to improve care, they're all digital. And they all from Datex, which is our normal way, but also from help desk tickets. We've had a single incident we've taken to the incident review panel, which was a no low harm incident to do with late medications. I scan these tickets every single day to make sure that we're not missing anything. That is a very good result so far, but I don't want to speak too early. We will do an interim risk and incident report to CSIC in 3 months' time and a full one in 12 months' time, like we did the last time. We've added an additional risk, only one additional risk to our risk register for EPR to do with insulin and feeding prescriptions, bearing in mind there are 68 there on there in the first instance. So now where are we? We're in the adoption period, which is jointly led by the programme and the sites. We'll be focusing on just making sure we're compliant with the workflows that exist. And we're doing a focused piece of work in outpatients and in ED and to do with the wards on the discharge. That will be followed by a period of optimization to make sure that we get the benefits of safer, better care that we promised in the business case, and then move on to a very technical description, which is HIMSS level 6, which is a level of digital maturity that not many trusts in the UK get to. Part of the trust already is there, and we want to get all 3 main sites at HIMSS level 6 in short order. So I'll leave it there, Mark, because doubtless there'll be some questions that me or Ravi or John and Debbie can answer.
They were. I hope governors had, because they fired lots of questions at me an hour ago, Alan, about the digital rollout, which I could barely answer, and I was hoping you would Alan, on that. But governors, who would like to go first? Bimbi, is that a legacy hand or a new one?
It's a new hand. Congratulations, Alan, and the rest of the team for driving this. It's really about the last thing you mentioned about HIMSS level 6 and the progression to that and the realization of that, because I know that has been something which has been a real aspiration. What are the steps to get to that, and what are the benefits that we will realize as a trust, in terms of ourselves and our patients?
Yeah, I mean, as you can well imagine, there's a whole industry in clinical informatics to show progress, but the real thing to get to benefits, the level 6, is the way that you use the system to improve care. So what it does is it's very simply allowing you to digitally improve care. So bringing the data by and large to the right people to make alterations in patients' care pathways, similar to what we do with CPGs, but on a wider level. The HIMSS level 6 also talks about the infrastructure that surrounds the software as well, talks about its resilience and its use by the staff as well. So it's no use having a system that's very good if it's not used in that way. So it measures compliance, it measures pathways and complete pathways, but also the end product of how it changes care. That's separate to the benefits realization piece, which is a little bit about safety metrics, particularly in the pharmacy side of things, but also in time reduction in patient care, so they wait less for their treatment. So there's a lot of measures about that. Hopefully that gives you a sense of it all. Bimbi.
Could I also ask about integration with primary care? I'm looking at Charlotte, who I know quite well from previously, about that aspect in particular, and I know this is something that really does impact on our primary care population and staff, really, and it'll be interesting to hear, does that translate from HIMSS level 6?
It doesn't feature as part of HIMSS level 6, interestingly. They only ever concentrate on internal ecosystems and not wider systems. However, the answer to that question is that the success of the EPR at Barnet and Chase Farm will be felt when as we're now live, that they're all free. And there's two main things, which is we pushed through the health information exchange at the start of the COVID pandemic. We were the first to have a mature system in North Central London. And what that does is it gives a live readout available to GPs, particularly through the EMIS system, which is pretty universal in North London. So they get a live readout of not all of the record, but the pertinent records at secondary care. It also flips over and is readable from our side as well, so that key bits of information, problem lists, recent biometrics like blood pressure and drug allergies are visible in your outpatients today. The second thing is also there's a readout of our data to health registries. We're building them up through North Central London's information group. They differ somewhat in that it's not about the individual patient record. Certain disease conditions or certain parameters are linked together in a registry so that population health decisions can be made upon that, but also can get drilled down to the patient level. So if you wanted to do some targeted work on a particular part of the population in a particular area, you could do that and then look at it even further to say, look at everybody who's smoking in that particular street, whether or not you wanted to see whether they'd had a review by their GP. That can happen now in the registries. It's very, very new. We're working very well with the neurology side of things and diabetes, and we've got a lot of faith that that's how we'll drive the population health going forward.
Thank you. Charlotte, actually, is quite a good segue to your question.
Thanks very much. I mean, thank you, Alan and team. I mean, yeah, it's a staggeringly large piece of work, and the comment that's just been made by Bimby about how it works for primary care. I mean, HIE and having the ability to read into each other's systems is totally game changing. Reduces wasted extra blood tests and diagnostics being done. We often see people who are presented very recently to A&E, and we can see the letters. I mean, a little bit of a delay whilst we're going through the process, which is completely understandable, and hopefully that will be smoothed out, but that's, you know, to be expected. My question I was going to ask is, when you upgrade one system, you've often all the other bits that fit onto it that interoperable often struggle, and so, you know, example, dictation systems and things like that. How can you sort of safety proof to know that, you know, we don't pick up problems in the future of bits of the system we thought would integrate together that aren't? Is there a way of testing, and is that, I presume that's a process that's being done?
Yeah, so there's two things, which is when we are bringing in this system, there's 3 big periods of testing which are end to end. So any alterations are tested to make sure that they work in a test domain so that the correct effect happens. So there's 3 levels of testing that happened before we went live, but also post go live in the early life support. They're tested again. We have done our own, so we get that through our contract with Cerner. That's the work that they do. We have got our own secondary assurance pieces, particularly about the things that you mentioned, which is referrals and letters going in the right place. And the other areas about pathology tests, mainly because they sometimes come from primary care, secondary care, and to a third party provider. So those assurance pieces are asked for, have been asked for in the last 2 weeks, and we keep an eye on that. We've got a visible report for these things to make sure that we don't end up with some of the difficulties that you sometimes get, which is like referrals that have not been reviewed, or reports of scans that have not been reviewed. Just to say, it's a little bit embarrassing about healthcare. Secondary healthcare is going digital now, as you saw in the HSJ today. About 50% of people are predominantly paper-led. GPs have been electronic for 20 years, really, by and large. So we're not as advanced as I think.
Thank you. Really appreciate it. I'm conscious of time. What I'm going to suggest, I'm going to bring in Sneha and Oswald for their questions or comments before you respond, Alan, and then I'll draw this to a close. As we do need to go into part 2 pretty quickly, as we have a guest for the first part of that. Sneha, please.
So, Mark, I'm taking a question on behalf of, I'm asking a question on behalf of Ella, which she wanted specifically to cover us off during the EPR section. So Ella's question was, if we have missing appointments whilst we are putting the system in place, how do we avoid it having an impact on the wait list? Because presumably if they're missing, there would be a knock-on effect on the wait list, times that the patient would have to use. So how do we manage that, and what's the process for it, and reassurance around that people wouldn't have to take longer because of a system error, if there is any?
Okay, I think
Alan, let's take Oswald's question as well, and if you can answer both together, but slightly quicker, trying to regain a couple of minutes here. Oswald, please.
The question I wanted to raise may not be related. There was a news item about Google having had access to a huge amount of patient information. Could you comment on that, please?
Ozzy, that's a good question. May I suggest we might take that in part 2, if you wouldn't mind. So in the next meeting, we'll answer that in the next meeting. After this, Alan, could you address?
The first question, just well, very briefly, which is that the data migration of future appointments was a big part of the program, and watched the automatic migration and then the subsequent manual migration that we did towards the end. It's got a series of audits that sit behind it as well. We heavily resourced that to make sure that any disruption was minimal. We were very careful to make sure anybody who complained of missing appointments, or indeed clinicians who looked at their lists and didn't see the patients they were expecting, that they were actually visited, and we got an explanation for every single one. There's a difference between a missed appointment or one that was taken off because we wanted to reduce the clinic size, and those that weren't visible at the time. Each one that's come to us and has been raised through our help desk has been investigated and reviewed, and every single and the number that has happened to is quite small to begin with, and it's vanishingly rare at the moment. But it is a separate work stream led by Matt Davenport.
Thank you very much. Ozzy, we will answer your question in part 2 of the meeting, was what I was trying to say under AOB, and we'll tell you what's happening with that piece. Alan, thank you very much. And I know, these huge rollouts will have teething problems, but what's really reassuring is seeing how colleagues have pulled together to get on top of them really quickly and to give the assurance. And as John said earlier as well, if asked when is the right time to do this, actually ahead of the winter pressures, because that unifies our working practices at some level across all 3 sites. Massive thank you to you and your teams on behalf of the Council of Governors. Okay, great, thank you. Going to move us on now to our governance and update items. So lead governors report, Sneha, please.
So I think lead governors report, it should be in the paper, so I'm not going to repeat that again, but the key highlight is the membership engagement survey that was sent on behalf of MEC. That was quite successful. I think comms, and as we created it, and we've got over 1,400 responses on it, which has been very, very brilliant. And there will be a playback to the council on the on a separate session on it. And we are working quite closely with comms to build up a membership strategy as well, where Meg is going to input and comms is going to help us lead through that strategy. So that's great. And finally, for medicines for members, we are looking to have ED as the topic, maybe end of November, early December. So that is something we'd be penciling in shortly. And finally, the committee assignment, Mark, we received some last minute responses. So probably we'll do it. We'll work with, I'll work with you to get them done later this week or early part of next month, so that we can update the council. So that's pretty much it from my side.
Thank you, Sneha. Any questions for Sneha? Well, great, thank you. That's very clear. Governor feedback from our committees. As we've had apologies from Vishal, we won't have his feedback. The committee feedback on the Clinical Standards and Innovations Committee. Hermant as well, I know could only attend part of the Population Health Committee, so we won't get updates from either of them this round. But if I may ask Charlotte, please, to give a quick update on the Nominations Committee, although granted a lot that will be picked up in part 2 in terms of specifics, and then after that, Linda, please, on Group Access Committee. But Charlotte first.
Thanks very much. So it's been busy last few weeks for the Nominations Committee, so predominantly been looking at working to the NED recruitment. We've been working with Odrys to help shortlist and sift, and then had interviews last week. Initially we were looking to recruit 3. So in terms of recruiting, we've found 2 very strong candidates. In terms of the candidates, and the third candidates, we're looking to strategically share a NED position between the North Middlesex, which there's a particularly strong NED, Sarah Rabson, who will look to do some part-time work with Royal Free.
I'm sorry to interrupt, Charlotte, apologies. So this is a meeting in public, so we should probably avoid the specifics, and then we'll cover that in the private meeting later.
Apologies, sorry, apologies.
I don't think there's much harm done. I would just ask whoever's recording this for the minutes, that we reflect that accordingly.
Okay, so we have 3 strong candidates that we're incredibly excited to work with, and please, in terms of other matters for the nominations committee, we've been looking with Mark in terms of agreeing chairs' objectives, and looking to work with HR in terms of setting those objectives in the future. I think I'll pick up most of it, the rest in terms of part 2. Many thanks.
Thank you. I know, as I also attended the nominations committee along with a number of other colleagues, it's been a particularly busy time for us. Thank you. Linda, please, Group Access Committee. We had our inaugural meeting.
Let me quickly check if she's there.
I think we might have lost Linda along the way.
Mark, she's not on the list.
Yeah, not to worry. Okay, so we're about to meet again as a committee, so we'll get the update next time. Oh, here's Linda. Hi, Linda.
Hi, apologies. I seem to I cut out. I'm not sure why.
No,
so,
a lot of us have been having problems. I've been thrown out twice already myself. So just after a quick 30-second, your update on the Access Committee.
So we've heard a lot today about the waiting lists and ED challenges, and this critically important at this current time board subcommittee was just recently set up with the purpose of monitoring and challenging the plans and trajectories put in place to ensure the Trust works towards meeting its constitutional standards and targets, and really brings together work currently being done by a number of different committees. So the importance of the work to be done by this committee has been emphasised by Mark chairing the meeting. And while at the moment there is a NED vacancy, it's hoped that one will be added at some point, hopefully soon, when we get maybe one of our new NEDs joining us. So the first meeting was held on the 31st of August and was just an introductory meeting which took us all back to basics and really set out the challenges currently faced by the Trust. The meeting was not fully attended, maybe because it was a day after bank holiday Monday, but the meeting was well structured and covered all areas really effectively. As Ravi mentioned earlier, the next meeting is tomorrow morning, and at the moment it looks like it's going to be fully attended, and hopefully it's going to start to address in more detail some of the areas highlighted as needing more analysis, such as the emergency department workforce challenges, which we've heard about today, and the initiatives currently underway to address this, cancer recovery plan, with spotlighting on the 104-week wait trajectory, referral to treatment plan, endoscopy recovery plan. So really, to conclude, as a first committee meeting, Mark ensured that the ground was set up for really effective follow-up, and he sufficiently challenged the information provided for everyone to collectively work on the appropriate steps to really improve performance and reduce the associated risks. So very early days, but it was, it was a very good first meeting, and I look forward to tomorrow's meeting, which I can report back on next time.
Thank you, Linda. And I think you and I both said, as we're both relatively new to the Trust, it was very educational, if nothing else, just to understand the dynamics of what's driving it. And I think we'll keep updating. But thank you so much for your support and contribution to the committee. Colleagues, questions from the public. I've not received anything in advance, but just, there's an opportunity now if there are any questions from the floor. No. Any other business, colleagues? Anything else that's urgent? I've not been notified of anything in advance, but okay, in which case, thank you very much for your support and attendance. Can I say big thanks to our executive colleagues as well for taking their time out in their extraordinarily busy diaries, to other board members, non-executive directors for supporting this, and other Trust members. And thank you so much to governors. And for governors, we'll go into our part 2 meeting, and there's a separate link for that in your diary. With that, I'm going to close this meeting. Thank you very much.
Thank you.
Thank you. Bye.